from your experience, how would you advise a health professional to work with the interpreter in the best position in the room, or the patient's own house, or in a hospital room?
Position yourself in a way that all three parties can make eye contact. So a triangular kind of setup works the best, as opposed to three people sitting in a line where you have to talk across one another. So something like a triangle where the health professional can make eye contact with the interpreter as well as the patient. If there's a family member present, then obviously you'd have to take that into account and position yourself so that you're not excluding them, but also the patient needs to be the focus, the center of the conversation.
And during the conversation, I've read guidance that suggests there are passive and active roles for an interpreter. Would you be able to explain what the difference in that is?
Right. Going back again to language fluency, people who've lived in this country for a long time normally have a certain amount of understanding of English. They may not be confident in speaking it, but they'd have a certain amount of confidence in understanding and definitely picking up a few words here and there. So a passive interpreter would be one who is asked to sit in on a conversation and listen to the conversation between the professional and the patient, with the patient using some English words, trying to get their point across. The interpreter would then be listening in just to fill in the gaps in case there were any. Okay. An active interpreter obviously would be someone who the patient doesn't have adequate English to converse at all, and then they need an interpreter to convey everything they're saying, or maybe they just feel comfortable having somebody put their words, give a voice to their words.
Is there a role for the interpreter in helping the health professional understand the cultural context, perhaps the faith context of why the patient is saying certain things? Is that an active role for an interpreter?
Kind of things that you can pick up in briefing and debriefing. Okay. So say you know that a patient comes from a particular background, you could tell the interpreter that at the outset before you go in to see the patient, and the interpreters would then be prepared. For example, say you were going to visit a Muslim family and you knew it was the month of fasting, the interpreter would then be able to say to you that the best time to visit would probably be a particular time of day when they're likely to be not praying, or in between the times that they break their fast. In the debriefing, the interpreter can also share things that they've picked up, non-verbals they've picked up during the appointment, or maybe family members have said something in the background which hasn't been interpreted, but which the interpreter has heard and then can feed back. It can have an impact on the conversation. So it could be that someone in the background has said, I don't want you to share this with the nurse. Make sure you don't tell the nurse this. That is something the interpreter can then share in the debriefing.
So if the family have said, please don't share this, the interpreter still does? Interpreters
are trained to share everything they've picked up.
Okay.
And normally if it is something sensitive, they would share it after the appointment. If it is something that's going to have an impact on the decision the clinician's making or the conversation, they would share it during the conversation. So if a family member is insisting on participating in the conversation, the health professional could say, can you just hold on please, we've got a formal interpreter here, a trained professional interpreter to convey the patient's words, but if you'd like to do some of the interpreting, the interpreter will listen in and feed back to me afterwards if there's anything that, are you okay with that? So consent and involving them and not making them feel left out, but equally not letting family members take charge of, because that's something that can happen where a patient is vulnerable and family members feel that they have the right to make decisions on the patient's behalf, would then rely on the clinician or the health professional to take the lead.
Okay, to manage that situation. Thank you.